Hey everyone, welcome back to another video. In this video, we are going to review non-invasive mechanical ventilation specifically for paramedics, talking about CPAP, PEEP, and how we can create these with the tools that we have available to us. We are going to start by discussing positive pressure. Positive pressure ventilation is an abnormal thing that doesn't normally happen in normal physiology. During normal physiology, when the diaphragm contracts, we create a negative pressure inside of our negative interthoracic pressure inside of our chest, and that causes a vacuum. I think of a syringe in that you pull the syringe down and creates a negative pressure inside, and then it will suck things into it. And that's what happens in your chest wall. Your diaphragm drops down and creates a negative space. Air comes in through your mouth and nose, down through your throat, into your trachea, and into your lungs. So in addition to causing breathing effects, that change in intrathoracic pressure changes has cardiovascular effects. So during inspiration, your diaphragm pulling down causes a negative intrathoracic pressure, and you can think of that pulling blood into the core, so increases preload of the heart. Additionally, as you create negative pressure, we actually decrease the afterload of the heart, and that causes increased cardiac output during inhalation. So the exact opposite is true when we provide any positive pressure, whether that be through a CPAP mask like this one, or through a bag valve mask, which would be higher typically as far as the amount of pressure that we'd apply. But that would what that does is increase our intrathoracic pressure, which would reduce our preload going to the right ventricle, I guess through the right atrium. So those effects are real, and it doesn't bother a patient that has stable hemodynamics. But if your patient already has levels of cardiogenic shock or septic shock, whatever the hyperperfusion could be because of trauma, it doesn't make any difference. But yeah, if you add positive pressure, then that can drop their blood pressure further. So we should be aware of that this is an immensely useful tool, but it also is applying some abnormal physiology, which has some effects to blood pressure. So let's jump in and talking about non-invasive mechanical ventilation. Now, non-invasive mechanical ventilation has changed greatly in my career, and the availability that's been available since 20 years ago when I started in an ambulance is that we have seen much more availability pre-hospitally of CPAP, and that has made a great benefit to the patients of decreasing the amount of needed for additional kind of advanced airway, fewer intubations, which are better for the patient. Now, when we talk about CPAP, we're talking about continuous positive airway pressure. So if we take a device like this, for example, and we apply this to the patient, it's going to push a gas up into the device, and as the patient breathes out, given that we have a perfect seal on the mask, we're going to create some positive pressure inside this system. And it's applied during the entirety of the respiratory cycle, so not just during inhalation, during exhalation, and during respiratory pause. So continuous positive airway pressure. Generally applied starting off at 3 to 5 centimeters and then titrating up to a max of 20. It can go above, but typically we wouldn't go, and often 5 to 10 will work for most patients. It will be increased based on its effects to the patient. So what does it do to the patient? In the airway side, it's going to decrease atelectasis, so areas of the lung that aren't being ventilated effectively. And you can think of those being collapsed airways or obstructed airways because of narrow, and this will help splint those airways open, both the alveoli and the tubes themselves. Which will then increase the amount of alveoli surface area that's available for diffusion. Also adds a little bit of pressure on top of the gas, so a little bit higher partial pressure of oxygen going across, I guess, all the gases, but we're thinking of oxygen going in, so it helps with the diffusion of oxygen across that membrane of the alveoli, and this decreases the amount of ventilation perfusion issues if you had an area of the lung that wasn't being ventilated, where you're getting blood to it but not getting enough air to it, and that will improve oxygenation. Primarily is what we're thinking of. Now, this will also help if a patient with sleep apnea will help splint airways open. So this has become very prevalent as more and more patients have sleep apnea. Will help splint their airways open while they sleep, so those soft tissues don't collapse in the upper airway and cause an airway obstruction, and they stop breathing and then wake up and do that cycle over and over again. So CPAP can splint airways open, both big and small, as you think through that. Now the difference between CPAP and PEEP. This is a confusing topic because these terms. So CPAP is continuous positive airway pressure, whereas PEEP just speaks to the positive and expiratory pressure. So it's just during the exhalation period and during that respiratory pause that PEEP is being applied. Now, I think that the easier way to think of this, and I like how Rosens has divided this, and what often is used in my experience, in the culture of practice that I'm in, is that CPAP is referred to something for a patient who's spontaneously breathing, whereas PEEP is something that we adjust for a patient who's not spontaneously breathing, or we're breathing for them, whether that be through a bag valve mask or through a ventilator. So these terms do get used interchangeably, which can lead to some confusion there, but hopefully that will help us bring some clarity around that. Now, if CPAP is a continuous airway pressure applied to the inhalation, exhalation, and respiratory pause. Now, BiPAP, now that's a trademarked name, the BLPAP, or the bi-level positive airway pressure, so there's two different airway pressures. And as you could probably guessed it, there's a higher airway pressure applied during inhalation, and then a lower pressure provided during exhalation and during respiratory pause. So those are the two pressures, one during inhalation, one during exhalation, and respiratory pause. So and this is really useful for patients who aren't breathing. Aren't breathing adequately. And how we're going to tell that is by their clinical context, their level of consciousness. Are they getting air entry? Rate of breathing. So patients breathe fast and shallow, often don't get adequate chest rise and get adequate air entry. Elevating levels of CO2. So definitely above 45, but most definitely we hit 70, we're definitely into altered level of consciousness in most patients and requiring someone to breathe for them. And so BiPAP is delivered for somebody that's not ventilating effectively. And we see inadequate ventilation as end-tidal CO2 skyrockets. So remember that end-tidal CO2 in a healthy patient usually is 2 or 3 above what PA CO2 is. So just the difference between. So there's that little difference. And as we get more and more areas of lung that aren't functioning appropriately, atelectasis, then we get a further disparity between what's actually the level of CO2 in the blood and the level of CO2 in the airways that the patient's breathing out. So that's a little bit about BiPAP and CPAP. Now, I just need to mention with BiPAP before we move on that typically those levels are of 2 different pressure. It's normally would be start off at like 10 centimeters of water pressure during inhalation, and then through the respiratory cycle, exhalation, respiratory pause would be 5 centimeters, and then that would be titrated by 1 or 2 centimeter water pressure until you get the appropriate clinical effects that you want. Now, the same would be true of CPAP, that we would start off with typically 3 to 5 centimeters of water pressure, depending on the patient, and then increase that by 1 or 2 centimeters of water pressure until we get the clinical effect that we want. Now, what is the effect that we want? We want increased oxygenation. So we would like to see the patient get better with this treatment. So if we're thinking of CPAP, we should see ease of respirations. I do find that this works after like 6 breaths. Patients start to see a benefit, so it doesn't take very long. So we apply this on, and we see ease of respirations. We get increasing oxygenation. We get leveling kind of CO2 into levels that we want. In a BiPAP patient, if we had really high levels of CO2, we'd like to see that come back down to normal with improving mentation, improving level of consciousness, and SpO2. So that entire clinical picture is what we're looking to create. Now, there's a way of providing CPAP that Scott Weingart, EM-Crit, advocated and has been published in a number of journals, is using a high flow nasal cannula, like 15 liters per minute of oxygen, setting your PEEP valve on your bag valve mask, and then holding that over your patient's face. And that will build up pressure, also helps make up for leaks inside of our system, but will function like this CPAP mask in the same way. Now, anytime that we have a high level of gas going into a system, it would be better to have nasal end-tidal CO2 on rather than through the system, because we're flushing it with tons of extra gas that we're putting into the system. So that would be a better place to read your end-tidal CO2. But why Scott Weingart has advocated this is largely around pre-oxygenation of the patient before intubation. So if you're having a hard time oxygenating your patient up to 100%, despite good ventilation and appropriate end-tidal CO2, whether that be the patient themselves or others, he advocates that you could try this. So it fits into our discussion in that context. Now, as far as contraindications for CPAP, a patient breathing on their own, and trying this, many EMS systems would have various contraindications. Now, UpToDate provides contraindications that would be there for sure. Absolute contraindications would be cardiac arrest, which seems obvious, respiratory arrests, severe respiratory distress, and unstable cardiac arrhythmias are their absolute contraindications. Now, if you go to a system like Alberta, they say CPR, which we see cardiac arrest, systolic blood pressure less than 100, knowing that this affects our preload. Vomiting or patient at risk of vomit or aspiration. Some systems would say not managing secretions, unable to maintain their airway, or have an impeded level of consciousness if you're going to strap this mask onto them. Now, when we turn into think of when we're applying the bag valve mask and providing BiPAP, we just need to be aware if we're bagging for that patient. Now, issues around level of consciousness and airway still exist, but we're able to easily access them, and we're supposed to continually monitor and suction as necessary and maintain airway patency. But that PEEP valve, we should be thoughtful around as we apply pressure in a patient that's not spontaneously breathing, that we can watch if our patient's hypotensive. So that should be very judiciously applied in that context and kept low typically. Now, who does this particularly help? The evidence points very clearly to 2 patients that this works really well, specifically to the CPAP. And there would be some some crossover with BiPAP. But with CPAP, who really benefits from this is the COPD patient that's got an escalating end-tidal CO2, but is still fully alert. That patient has responded really well, and there's lots of evidence to support the use of CPAP in the patient. The other patient that would be useful, and we can see why that's useful in that COPD patient, that we've got kind of collapsed alveoli, increased inflammation, mucus production, so splinting open of those small airways and those tubes would be helpful in decreasing areas of atelectasis, and that's how it's primarily helping that COPD patient. Now, in pulmonary edema, cardiogenic pulmonary edema, so I want to say acute decompensated heart failure, in that patient, This has helped both from the airway side and maybe pushing some of that fluid back from the air side through the alveoli into the back into the blood space, into the plasma. But additionally, this is helping by increasing interthoracic pressure and decreasing the preload, which would directly decrease the output of the right ventricle, which allows the left ventricle to catch up. So I often think of the right side of the heart, left side of the heart, and in acute decompensated heart failure, the right side of the heart is working well, and the left side of the heart is typically not. And that produces a high blood pressure between the two and your pulmonary arteries, and that's supposed to be a small, low pressure tube, and then it leaks. So if you can decrease preload, you will decrease the amount of ejection for right ventricle and decrease pulmonary edema. And that's how that's helping, or one of the mechanisms that's helping our acute decompensated heart failure. Now, other patients that are less likely to benefit, but are still, the research is still being ongoing, is patients with asthma, pneumonia, ARDS, or chest trauma. There's not as much conclusive evidence that this is helpful at this point. It might turn out to be. And some clinicians are trying this, and lots would advocate that you could try a short trial of CPAP, given that these patients have no altered level of consciousness, marked hypotension. Definitely those absolute contraindications that up to date would rule that out. But barring no contraindications, maybe CPAP could be tried. In asthma patients, many experts have recommended at starting low and keeping low, remembering the profoundness of their difficulty of getting air out. So we're kind of balancing that increasing airway pressure, but also against splinting airways open. So it may be helpful to do a trial of that. In other conditions, may be considered, but where the overwhelming evidence is this is good for COPD patients that have escalating end-tidal CO2 and acute decompensated heart failure patients with a good blood pressure. This is where this has been most successful. So I hope that's helpful and brings some clarity around CPAP and PEEP, and then BiPAP and our kind of application and which patients we might treat with that. Until next time.